Good morning. This is the Senate Health and Welfare Committee meeting of January 18th. Good morning, everyone. We have some work before us today. Before we begin, I'd just like to comment on the mask requirement bill that we have been looking at. And leadership continues to discuss the path forward for that bill. It was scheduled for this morning, but we're going to postpone our work, and hopefully it'll be only until tomorrow morning. We'll keep you posted. And I'm asking Ledge Council to just go through the draft for spelling or similar changes so that when we do come back to it, we're ready to go. So that's it on the mask requirement bill. And we're going to move on into our agenda to S74. And I believe, Jen Carby, you are here. Good morning.
Good morning.
Yeah, it's good to see you and everyone else.
You as well.
So we have had testimony on S74, and I know that there are folks out who have continued to send emails about the bill. So we're going to just move forward with what we have at this point. I haven't heard for further testimony at this time. So Jen, we're going to go through the bill, and I know that you've had conversations with folks who testified on the bill, and we'll look and see what that conversation has led to, if anything. So are we still at the
So I have
bills?
not actually spoken with anyone. I don't believe. I had reached out to the Attorney General's office, but did not hear back.
Okay.
And I have reached out to DEVA to try to get some information about Medicaid coverage, but have not.
As I understand it, the insurance issue is fine, it's taken care of. So I don't think we need to follow up with that one. The one that I'm most concerned about is charities from the AG's office. So let's go through the bill, and then we can get to decision points as needed. Senator Cummings.
Yeah, the thing I heard the other day that I'd just like to check on is that there's been some issue with getting the medications, and that some of the medications haven't been working as planned or as people thought they would. And I just thought we might want to
So yeah, here's
follow
what
up on that and make sure everything's in line.
I've heard that as well. Most of the emails I've gotten about that have been from out of state and from organizations out of state. I think
This
that
apparently was grand rounds at UVM. So
that one. Yep, I saw that one as well. So what I'm going to suggest is we go through the bill with the technical corrections that have been substantiated with data from the program itself. The medication issue gets into a bigger discussion that I think in some ways falls outside of what we might be able to accomplish at this time. So I understand it's an issue, and perhaps we could suggest to the Department of Health and others that they evaluate those medications. It seems like a medical decision. So let's go through the bill, and then we'll see where we get to.
Do you want me to put the bill up on the screen, or do you want to be looking at it?
I think so. Yeah, let's put it up on the screen, and we're all looking at it at the same place, the same time, and we can draw our conclusions as needed.
Great. Thank you. Aaron has made me co-host. All right. So here is the bill. Can you all see that now?
Yes.
Great. So this is S74, an act relating to modifications to Vermont's patient choice at end-of-life laws. And the first changes are in section 1 of the bill. It would amend 18 VSA section 5283, which is the list of items, a list of actions that must occur in order for a physician not to be subject to liability or disciplinary action. And the first of those deals with the patient making the oral request to the physician in the physician's physical presence. The proposal here is to eliminate that. And I think there are a couple of options. You had heard about some talk about telemedicine being appropriate. So one option might be to specify that this can be done through telemedicine. Otherwise, it does not require any physical, any visual contact between the patient and the provider. I think if you take out the language, it would allow telephone call as well as audio video. And if you have a preference there, then we may want to specify.
Madam Chair.
Go ahead.
Jen, thank you. I think that's a good suggestion, particularly given the testimony we received last week from Dr. Barnard, who described what she does to assess a patient. So if you're able to add that in, I think that would be helpful.
Where exactly, can you just share with us where exactly that goes in the process? The overall process?
These requests?
Mm-hmm.
So this is, there are requirements for this process to occur that the patient make 2 oral requests to the physician at least 15 days apart for the medication. And then, and there are other things that occur throughout the process, but aren't necessarily happening at that same time.
So this would add language within number 2 or number
So to add
1?
language in numbers 1 and 2,
Okay.
presumably, and similarly take out language requiring this physical examination.
Right. It's already happened.
Well, so with the language that is proposed here, I believe the entire physician-patient interaction with respect to this part of the process may happen without a physical examination. There is earlier, and just in the definition of bona fide physician-patient relationship in the chapter, a requirement that there be a treating or consulting relationship in the course of which a physician has completed a full assessment of the patient's medical history and current medical condition, including a personal physical examination.
Yes, that's exactly what I was getting at. So we're looking at that established relationship, and then this is at a time when the patient may have difficulty in getting and transporting him or herself to the physician's office, among other things.
Okay.
Yeah, thank you. Senator Cummings.
Yeah, but we're allowing a teleconferencing, not just the telephone call. Is that correct?
Yes, I
Well,
think
that's what you're discussing is,
Yes.
so with the
I
way the
would
language is
be-
proposed.
Yeah, I would be uncomfortable with just the phone call.
Yeah, I
And
think, and Senator Cummings, given the testimony we heard last week from Dr. Barnard, I think specifying that in the physician's physical presence or via video telehealth
Right.
is what
I
I think
think-
makes sense.
Yeah.
And I will note, I just, as I was reading you this definition of bona fide physician-patient relationship that requires a physical examination. That term is actually never used in the chapter. I think it's a holdover from earlier drafts of the bill when Act 39 was in process. So there may not necessarily have been a physical examination of the patient if you eliminate this requirement about the terminal condition being based on a physician's physical examination of the patient.
So in other areas, the decision, for other medical procedures, the decision is up to the doctor when when and in what form the telemedicine communication would take place or be appropriate. So I'm thinking maybe that is a better, maybe that's language that we could use to say, as for other medical procedures, it is up to the doctor to decide when and in what form telemedicine is appropriate. Throw that out.
Well, we may want to look at the laws, and I'm just pulling up the statutes on statute in also in Title 18, 9361, I believe, is where it talks about telemedicine generally, and the duties for healthcare providers. And there's, you know, there's consent required. I don't think it specifies. There was language when you worked on the audio only telephone coverage last year that talked about being clinically appropriate for telemedicine. I don't believe that's, or for audio only telephone. I don't believe that same language exists in your telemedicine law around the healthcare provider side of it. It may exist in the insurance coverage piece.
Okay.
So if there's a particular, I guess what I'm saying is if there's a particular message that you're wanting to convey about telemedicine, then let's be explicit about it, but I wouldn't tie it to other types of, to what's specified elsewhere in statute, because I'm not sure it is specified elsewhere in statute. So if you want to say something in here about, if, you know, the provider determining it is clinically appropriate to do this by telemedicine, I think that's fine. We can certainly put that in there, and that might be the right terminology.
That makes sense. So what do you think about that, committee?
Where are you talking about specifically?
Where we were. We were up at 1 and 2, I think.
And Jen, could you
Yes.
just tell me which chapter the medical aid in dying is in Title 18? I'm trying to find.
Yes, it's 113.
113. Okay.
Yep. So
Jen,
I'm
so-
looking
so
at
Section
something
1.
like, whoops, now I went too far. Made an oral request. So something like the patient made an oral request to the physician in the physician's physical presence, or using or by telemedicine, as defined in our other telemedicine statute. If the physician determines telemedicine is clinically appropriate.
Do we want to say anything about what form of telemedicine is clinically appropriate?
Well, we're going to use telemedicine, so we're not using telehealth.
Oh,
That's the
Okay,
larger
we're using
term that
telemed.
can,
Yep, got it.
right. So telemedicine, and I would recommend that we tie in the definition from actually Title 8 that gets carried over into the telemedicine healthcare provider statute, that defines it as the live synchronous audio video.
Okay.
Oh, okay, so
Interaction.
let's do that. Let's put that in and see how that looks to us.
Okay. Yes, and I'll want to spend a little time sort of looking at the language and how best to phrase it. So it's
Okay.
not, I'm not loving how I'm saying it now, so I'll look at how to phrase it so that I think it captures what you're saying.
And
We get it.
Jen,
Okay.
I am looking now at chapter 113. There is a definition of bona fide physician-patient relationship in that.
There is, but that term is then not used again in the chapter.
Oh, I see. Okay.
So it defines it, but it doesn't actually come up. So the definition is sort of irrelevant.
I see.
I think it was just a holdover there were a lot of different versions and approaches being drafted when Act 39 was a bill in the legislature. And I think that was just a holdover from an earlier version that did not end up in the final.
Okay, so let's try that, and then we'll look at the new improved language from Ledge Counsel Carby.
Mhm.
And
Great.
and then why don't we move along? That's a good,
Okay.
a point well made.
And I know there was an issue, and I think David Englander had largely addressed this at the time, but there was an issue raised about whether there's a concern around telemedicine and whether whether it's an out-of-state provider. Based on our definition of healthcare provider, it is somebody who is licensed in the state. And in addition, a provider has to be licensed in the state, except right now during COVID, where, as you know, there is the option for licensed out-of-state providers to provide treatment to Vermont patients without being licensed in the state. Otherwise, there is a requirement that the provider be licensed in the state where the patient is physically located. So I don't think there's anything additional you need to do there when we're under normal circumstances, unless there's something that you want to specify in this particular COVID time.
No, I think the place
and
for
that could be-
that would be in the COVID bill, if at
Right.
all.
Right.
Yeah. Okay.
Okay, so those are the changes in 1 and 2, and the other subdivisions 1 and 2. The other change here is really a technical one, from just a grammatical one, from no fewer to not fewer. And then in number 5, this is removing that requirement that the physician have done a physical examination of the patient to determine that the patient is suffering a terminal condition. This is a requirement for an examination and a review of the patient's relevant medical records, but does not require the patient to be physically examined by this prescribing provider.
Well, Jen, so that would take place prior to the other 2 via telemed, or potentially via telemed, right? This would be like the initial exam. Is that correct?
It does not specify the timing in which the provider is making this the physician is making this determination. So there are a number of steps that have to occur, but other than the at least 15 days between the oral requests, also a written request, and then we'll look at it in a minute, the 48 hours for the physician to write the prescription. It doesn't specify the order in which these have to occur. So I think arguably you could have the physician or the patient make the first oral request, the physician make the determination that the patient is suffering a terminal condition and other things at that time or after that time, but they have to have made this determination before they write the prescription.
Okay. And
there,
And
it may be difficult to see some of this out of context. This
yeah,
bill
yeah,
is just showing you
yeah,
the high
that's
points
one of the
what's
things that
changing.
is difficult, is it is out of context, so it's
Yep.
helpful.
Do you want me to
as you're-
put up the statute?
Not right
that
now. Let's
be-
keep going, and then we'll continue to ask questions to clarify. But it might be helpful at some point to go through the process again, the statute.
Right. Okay. So that's where the other physical examination piece comes in. And then this is, and I know you took a lot of testimony on this, number 12 is the requirement that the physician waited at least 48 hours after the last to occur of the patient's, and you can't see these, but this is the last to occur of the the patient's written request for medication, the patient's second oral request, and the physician offering the patient an opportunity to rescind the request. So that's the 48-hour waiting period that you have heard about after the oral request. The patient's second oral request is, I think, what people have been focusing in on. And the request to eliminate that 48 hours.
Yeah, but the 48 hours comes after the 15 days. So they made the
Right.
request, and then there was 15 days, and then there are 48 hours after that, after the.
Right, and actually, at the time of the second oral request, under the existing law, and this would not change, the physician has to offer the patient an opportunity to rescind the request.
Oh, okay, that's right.
So, this is 48 hours, at least 48 hours after the last to occur of the patient making the written request, the patient making the second oral request, and the physician offering the patient an opportunity to rescind that request. So the question is, do you want 48 hours to have elapsed after the last of those before the physician writes the prescription, or do you want some lesser amount of time?
Jen, just to clarify here, I'm looking at the statutes too, just because it's hard to track on the bill, but
Mhm.
it is an or, not an and. And
It is.
do you think
I think it doesn't, as I've been looking through this, I've been thinking, oh, I wonder why it says or and not
Yeah.
and. I don't think it matters. I mean, it's still the last to occur of the following events. So it still requires all of them to have, I believe, to have occurred. I think it's confusing the way it's written.
So,
But my recollection of the discussion and the way the process has works is that it's the last to occur of all of those. I think that the or is there to identify that only one of them would be the last.
okay. So
But,
you think
but
it's
I
okay?
agree that it is confusing.
Yeah, I read it 3 times to say, okay,
Yeah.
does this make a difference if it's an and or an or should there even be a word there?
Conjunction.
so
Yes, I think I think it does not matter. I think the impact, the effect is the same, but it would be clearer if it's at and.
can I make a suggestion for
Sure.
everyone? So we all have our computer screens up. If you have your iPad, you're not using that separately. If you go to January 12th and under Betsy Walkerman, you click on the graphic act flow chart, and it shows the process. So
Oh, great.
yeah, but there it is. So it's something to look at in addition to looking at the statute that Ruth is looking at.
I just want to make sure that there's not something else that we should clarify
Yeah.
to make it more clear. And that's why I was wondering about the and or the or. The and
Good.
and the or the and. Yeah.
Good catch. So what did you decide? Jen, what did you and Ruth decide on that one?
I think it would be clearer if it said and. I'm not sure if you want to make that, if that's something that you want to address, I'm happy to make the change.
Well, let's put it in and then we'll see what happens
Okay.
with it.
I will, yes, I'll consult with David Englander too and see if he has a sense for
Okay.
whether there's a practical effect there. I don't believe there is. But I think it is clear with an and. So that is the end of proposed changes to section 1, or in section 1 to this 18 VSA 5283. Is there anything else you wanted to look at on that section, or do you want to move on to section 2?
Let's just keep going, I think.
Okay. Section 2 adds to the limitations on action. So in the existing law, there are provisions around no provider being under any duty to participate in providing this medication to the patient, and that a healthcare facility or healthcare provider cannot subject a healthcare professional to discipline, suspension, loss of license, loss of privileges, or other penalty for actions taken in good faith reliance on the provisions of the chapter or refusals to act under the chapter. And then there are, except as otherwise provided in a few other sections, nothing in this chapter shall be construed to limit liability for civil damages resulting from negligent conduct or intentional misconduct by any person. And this would add in as a new C, so that would move down to D, and this bill in section 2 would add that no person shall be subject to civil or criminal liability or professional disciplinary action for acting in good faith compliance with the provisions of the chapter. So in existing 5285B, it's really focused on not subjecting a healthcare professional to professional disciplinary action for actions taken in good faith reliance on the provisions of the chapter or refusals to act. And this would add that nobody would be subject to civil or criminal liability or professional disciplinary action, which in some ways overlaps with what's already in there for the healthcare professionals for acting in good faith compliance.
Okay. Then you haven't contacted the AG's office again regarding this, but they
Have not
were-
heard back from them, no.
haven't heard back from them. So silence is silence. My concern is if we start listing all the different possibilities here, it gets extremely complex. So for this really is very helpful as far as I'm concerned, but I'm open to others.
And I think the concern you'd heard from the Attorney General's office, and this is the piece I don't have enough information about what their concern is, but is about this good faith compliance, which they suggested was introducing a new element, although I will point out again that 5285 already has good faith reliance as far as the professional disciplinary action, but not the liability. And then this D does not limit liability for civil damages if somebody is acting negligently or with intentional misconduct, and that generally would not, it is incompatible with good faith compliance. So if they're acting negligently or with intentional misconduct, that is not.
And
believe
the
good
other,
faith compliance.
the thing that we heard in testimony was that there's one pharmacist who's willing to prescribe because of a concern about liability issues. So this.
Right. And so one possibility, if you were concerned about the breadth of this, would be to include or to, I guess subsection B includes other person as well, but we could name no physician, nurse, pharmacist, or other person, which I think would not narrow the breadth of it, but would specifically name pharmacists if that is part of the concern currently around liability.
I think that is a concern. So committee, I'm just asking what your thoughts are on that phrase. Medical provider, nurse, pharmacist.
I think the way it's there is better, because if we start listing somebody, we might leave somebody out. And then if you leave somebody out, then they might get worried that they're left out and could.
The existing language in B is physician, nurse, pharmacist, or other person. So it's still, so if you use that same language in C of physician, nurse, pharmacist, or other person, I don't think you're leaving anybody out.
Okay, fair. Okay.
So what's wrong with doing that?
But I mean, there's no, from a practical standpoint, it's no different from saying no person. You're just specifying some particular people. And the only reason you might want to do that is if it gave more comfort to pharmacists, if that's, one of the.
Well, it does offer clarity. Yeah, it does offer clarity.
You're looking to assuage.
Senator Hooker.
Sure, thank you. When Dr. Barnard spoke, she spoke about the health team, the healthcare team, and I had asked, who that included. So I don't know if that is something that we might consider rather than no person, but.
Well, we'd have to define health team, but I'm not sure that, Jen, is there a definition of that anywhere?
No, I think it's a
Different health
term of art in
team.
the industry.
She did suggest that it was anyone who was, taking care of the
Right.
patient. So, and that I think is an important concept, that
So-
anyone who's anyone who's in charge of
Yeah.
person's health care should be protected if this person is making the decision.
Okay. Senator Cummings.
Okay. Maybe we could do something like healthcare professionals and pharmacists. Any person, there's been a concern about potential abuse, and any person might be read to include those people that there was concern about might be pressuring people. Any person is pretty broad. Any professional person might cover it. But I don't think, to me, the pharmacist isn't part of the healthcare team. Healthcare is doctors, nurses, palliative care people, hospice personnel, but the pharmacist is in a shop 20 miles down the road and isn't part, there's not like he's discussing with them what's the best medication. So I think we need to specifically mention pharmacists.
So the language that Jen put forward, and I'm thinking that currently with this language in the act, we haven't seen concerns of abuse, or liability issues raised. So by putting that phrase in here, it does offer reassurance for the pharmacists and others, and it's consistent with what's in the underlying statute.
So there is a definition in the beginning of the chapter of healthcare provider, which is a version of one that we often use we often use in statute. It's a person, partnership, corporation, facility, or institution licensed or certified or authorized by law to administer healthcare or dispense medication in the ordinary course of business or practice of a profession. So we could, if you wanted to keep it narrower, we could say a healthcare provider or no healthcare provider shall be subject to civil or criminal liability or professional disciplinary action. I will note this definition of healthcare provider specifies dispensing medication, which is what a pharmacist does, although generally in our larger use of the term healthcare provider typically does include, or healthcare professional does include, a pharmacist in that category. So while they may not be physically present or part of what may be contemplated as the healthcare team, they are delivering a healthcare service. So we could include healthcare provider.
I think that definition of healthcare provider is actually more broad because it includes institutions, et cetera. And I don't necessarily want to do that. So I think I understand, Anne, your concerns about the other person. In B, in the current law, that's talking about licensure or loss of licensure privilege. So that would be only covering licensed people. But I'm just wondering, Jen, for example, if a spouse were present, during the whole process, which I think is common, would, if we didn't include other person in the list, would the spouse potentially be liable, or could?
No, because of this previous section. So section 5284 is no duty to aid.
Oh,
and because
okay.
Exactly what you're talking about was raised as a concern during the development of this legislation. And so that specifies that being present, just by being present when somebody self-administers or not the medication, or not acting to prevent the patient from self-administering, does not subject them to civil or criminal liability.
Okay. So in that case, then, if we did under C what Senator Cummings, I think, is suggesting, instead of saying no person, saying a physician, nurse, pharmacist, or other medical professional, I guess, shall be subject to. Is that what you're thinking, Anne?
Yeah, I think we need the issue has been pharmacists, and I think we need to specifically mention them because they are not, generally in my mind, I don't see them as healthcare workers.
Right, but to not leave it open to anybody else.
Anybody, yeah,
Right.
anybody.
Does that make sense, Jen? Or is that?
Yes, I do want to be, I do think, I don't want to get into a debate about it. I do think pharmacists are typically considered to be a healthcare professional. It's just as opposed to being in some other field. But I certainly think we can specify no physician, nurse, pharmacist. If you want some kind of or other something, I think we're going to need to define what that category is.
Yeah, maybe
you know,
we
I-
do need to use healthcare provider.
Well, we don't necessarily. I think we can, I think we can even tie in, or anybody else licensed, certified, or otherwise authorized by law to deliver healthcare services, and we can piggyback on an existing definition of healthcare services or something like that. I mean, I think we can. So I think we can accomplish the result, but I think we're going to need to be mindful of how we're doing.
Okay. Do
Um,
you think you have enough direction to do that, or do you?
I think so. Yeah.
Okay.
Well, yeah, I'm with you on this. I'm still thinking that by listing the folks who are already listed in the bill and adding pharmacist accomplishes our goal, but let's see what you come up with. I'm open to this. And we did get a letter from Steve Hochberg, the pharmacist who dispenses these drugs. And it was a very compelling letter, very empathetic, and his relationship with these patients. So I'm trying to find that letter. And I know I have it. So I'll keep looking for it.
I don't
don't have it.
remember. I don't remember getting that. And it's not on our website. If you have
We
it.
haven't, it was not put on the webpage. I think it was sent either to one or more of us, and it was just a letter, how we get letters from folks. So if I can find that letter, I will, we'll get it on the webpage and you can see what he says. Because I think it will help understand the relationship that Senator Cummings is concerned about. Okay, Jen, where are we at this point? Effective date? No.
Yeah, I think we're at
Okay.
the effective date. Unless
So-
there are other changes that you're interested in making.
Can we do this? Can we go through the changes that we have made at this point, or the language that we're going to look at next? Go through it from the top. And then I'm going to suggest that we take a break and ask you how long it would take to put those changes into language so we can actually see them. Let's go through one more time. You can share with us what decisions have been made, and then we'll take a break and come back.
Okay, so in the first section, section 5283, which is the requirements for prescription and documentation, we talked about in these two provisions in 1 and 2 that currently require the oral request to be made in the physician's physical presence, that instead of striking that, we would add or by telemedicine, as defined in our existing statute, as long as the physician determines telemedicine to be clinically appropriate for medication to be self-administered, et cetera. So putting in language to that effect about affirmatively authorizing telemedicine to be used here. Removing this language about the physical examination in 5 as proposed. In 12, I guess, I'm not sure if
Wait.
you, yes.
Sorry, that back to 5. I think we didn't totally make a decision there. It was sort of, we put a pin in it.
Okay.
No, I
And
thought we were good. I thought we were good, but go ahead, because we put it in context with the rest of the program, but what were you thinking, Ruth?
Well, I was trying to look at statute to see what the whole process is, to see it doesn't seem quite right to me that the whole thing could be done without any physical examination.
No,
And
I think,
so that's why I
yeah,
wanted to make sure that there is a part that there is a physical examination and if if taking out physical here means that there's no physical examination, then that I think is problematic.
no, we went back. Remember, I think Jen went back and
No,
we
I
looked-
believe that
Go ahead.
taking physical
Yeah.
out here would eliminate, I had gotten briefly confused by the definition of bona fide physician-patient relationship that includes a physical examination, but then that term is never used in the chapter, so that physical examination requirement doesn't come into play.
Oh,
So this is the only place, I believe, and again, there were so many changes in the way the bill was approached throughout the process, and the way it ultimately turned out was through the physician lens as opposed to the laws in other states, which just kind of lay out the process. This one is done through not imposing liability on the physician if the physician does all of these things. So it does not require a physical examination, as I understand it, if you take this language out.
Yeah.
well, okay, so clarify then, because we went back and looked at the physician-patient relationship that must be established before any determination is made. It's not there. What are you, in the beginning of,
In the very beginning, in the definitions, there is a definition of bona fide physician-patient relationship. That is because in earlier iterations of the bill that became Act 39, there had been a requirement for a bona fide physician-patient relationship of, I believe, at least 6 months or something like that, before the physician would be allowed to prescribe medication. That was not included in the final version that was enacted. And so this definition of bona fide physician-patient relationship that specifies that it includes a personal physical examination, because that term is never used in the chapter, it does not pull in that requirement for there to have been a personal physical examination. And so I believe the only place in the law now that requires a physical examination is this reference where the physician determined that the patient was suffering a terminal condition based on the physician's physical examination of the patient.
okay, well, I suppose leaving it in then is reassuring that there is a physical examination. We have allowed for telemedicine, so,
We've allowed for telemedicine sort of later in the process when they're
Yep.
requesting the medication. But if
So-
we get rid of this physical, then there would be no,
there's no physical.
yeah.
If we go back to, I'm looking again at the summary that Betsy Walkerman sent us. Okay, let's, Jen,
I
let's.
mean, I
leave-
think
So, Madam Chair?
Oh,
can
yeah,
I-
go ahead, Chair, Senator Hooker, go ahead.
Thank you. Are we talking two different physicians here? You know, the person who determines that the person is terminally ill, and then if the patient goes to another physician, that physician just has to examine the records and then make that determination? I'm confused as to, you know, how many physicians are involved.
yeah, it may be, and it may be helpful for us to look through the whole list of requirements. I think with you getting them piecemeal here, it's hard to get a picture for what the whole process looks like. Would it be helpful to look at the language on that? Or I can redo the language on that?
Well, let me make a suggestion that we leave physical examination in because it sounds very problematic in terms of having that relationship. And then let's keep going through, and then Jen, it would be great to go through the whole thing, the whole process
Okay.
that we have.
Because I think you get, it gives you a fuller picture of what's involved, which may help you decide what
Yeah.
pieces you feel comfortable changing and what pieces you do not.
Yeah. This reminds me of going through the toxic chemicals in children's products with all the rules and the 2-year exemptions, timelines.
All right, so it sounds like we may be leaving physical in for now.
Yeah,
In subdivision 12, this is the question of whether you want to take out this 48-hour waiting period after the last two occur. And we talked about changing the or to and to be clear about all of the events. But I'm not sure. We talked about the or to the and, that one I was there on, but I'm not sure if you had made a decision about taking out the 48 hours.
committee.
Yeah, the 48 hours is okay.
Yeah, okay.
Yes.
Okay to take out?
Yeah,
Yes.
yeah. All right, the
I'm
next
noting
one.
that to myself. And
That's good.
then in section 2, we talked about changing this proposed subsection C to say no physician, nurse, pharmacist, or other individual who is licensed, certified, or otherwise authorized by law to deliver healthcare services as defined in such and such in this state shall be subject to civil or criminal liability or professional disciplinary action for acting in good faith compliance with the provisions of this chapter.
That works.
Okay,
Okay.
so that's
And
good.
then-
Yeah.
And then that would take effect on passage.
My question for the committee is, do you want to look at the entire process now? Or would you rather have Jen come back with new language and then look at the entire process and where this all fits? Jen, what's your preference?
I think it may make more sense for you to see what the whole process looks like in case it changes your position on changes that you do or don't want to make.
Okay,
Yeah, I
So-
think that would be helpful. I agree. And Jen, also thinking about whether or not, since the language on the bona fide relationship is not actually used, if we want to either link it in some way or get rid of it because it's confusing. I don't know which is better, but it seems silly to have it in there if it's not serving a purpose.
I'm always in favor of getting rid of definitions that aren't being used because I agree that it can be confusing. As I mentioned, there were a lot of moving pieces in this throughout the process, and I think there are probably a number of tweaks that could be made, but I'm happy to look at those with you to the extent you want to do that.
okay.
All right,
What do
I'll
you,
put
what,
up-
why don't you walk us through very quickly here?
Okay.
Quickly, this
and-
is not a quick.
No. So I will just show you, sort of hit some of the high points in the chapter as well. So there's definitions. We won't necessarily go through those right now, but there is right to receive information, and physicians are allowed to provide information about the law and the process. So then these are the requirements. Physician shall not be subject to civil or criminal liability or professional disciplinary action if they prescribe to the patient with a terminal condition medication to be self-administered for the purpose of hastening the patient's death, and the physician affirms by documenting in the patient's medical record that all of the following occurred. So the patient made an oral request to the physician in the physician's physical presence, and we'll be adding telemedicine here, for medication to be self-administered for the purpose of hastening the patient's death. Not fewer than 15 days after the first oral request, the patient made a second oral request in the physician's physical presence. Again, we'll be adding or by telemedicine. At the time of the second oral request, the physician offered the patient an opportunity to rescind the request. The patient made a written request for medication to be self-administered for the purpose of hastening the patient's death that was signed by the patient in the presence of 2 or more witnesses who are not interested persons, that term is defined in the definition section, who were at least 18 years of age and who signed and affirmed that the patient appeared to understand the nature of the document and to be free from duress or undue influence at the time the request was signed. The physician determined that the patient was suffering a terminal condition based on the physician's, and this is where that physical examination piece is in there, physical examination of the patient and review of the patient's relevant medical records. So these are, the physician determined that the patient also was capable, was making an informed decision, had made a voluntary request for medication to hasten their death, and was a Vermont resident. And the physician informed the patient this one is in person as well. So I hadn't actually noticed that one. That's why it's good we're going through it. So we may need to add or by telemedicine there. Both verbally and in writing of all of the following. So the physician informs the patient of the patient's medical diagnosis, the patient's prognosis, including acknowledging that the physician's prediction of the patient's life expectancy was an estimate based on the physician's best medical judgment and was not a guarantee of the actual time remaining in the patient's life, and that the patient could live longer than the time predicted. The range of treatment options appropriate for the patient and the patient's diagnosis. If the patient was not enrolled in hospice care, all feasible end-of-life services, including palliative care, comfort care, hospice care, and pain control. The range of possible results, including potential risks associated with taking the medication to be prescribed, and the probable result of taking the medication to be prescribed. Number 7 is that the physician referred the patient to a second physician. So here's the second physician for medical confirmation of the diagnosis, prognosis, and a determination that the patient was capable, was acting voluntarily, and had made an informed decision. Number 8, the physician either verified that the patient did not have impaired judgment or referred the patient for an evaluation by a psychiatrist, psychologist, or clinical social worker licensed in Vermont for confirmation that the patient was capable and did not have impaired judgment. If applicable, the physician consulted with the patient's primary care physician with the patient's consent. The physician informed the patient that the patient may rescind the request at any time and in any manner, and offered the patient an opportunity to rescind after the patient's second oral request. The physician ensured that all required steps were carried out in accordance with this section and confirmed immediately prior to writing the prescription for medication that the patient was making an informed decision. The physician wrote the prescription no fewer than 48 hours, and that's the piece talking about taking out, after the last to occur of the following events: the patient's written request for medication to hasten their own death, the patient's second oral request, or the physician's offering the patient an opportunity to rescind the request. So again, we're talking about changing that or to an and.
Jen, sorry
Yep.
to interrupt. Since we're doing this, in an A, I believe you all have a way to make things non-gender specific.
Yes, I can go through. I mean, we can do that in all of these. I think it's throughout here that there's a his or her own death, even in the, maybe it was in the first. Anyway, yes, I can make that gender neutral if you'd like. Yeah, I lost her.
That's okay with everyone. We might as well, since we're
Yeah, good catch.
updating.
Good catch.
Actually, it's not gender neutrality, it's non-gendered.
Non-gender.
And yes, we are making affirmative efforts to remove gendered language throughout the BSA. Okay. Number 13, the physician either dispensed the medication directly, provided that at the time the physician dispensed the medication, there's another gendered language, the physician was licensed to dispense medication in Vermont, had a current DEA certificate, and complied with any applicable administrative rules. So the physician either dispensed it directly or with the patient's written consent, contacted a pharmacist and informed the pharmacist of the prescription, and delivered the written prescription personally or by mail or fax to the pharmacist who dispensed the medication to the patient the physician, or an expressly identified agent of the patient. The physician recorded and filed the following in the patient's medical record.
Wait,
The
Jen,
date, yep,
sorry to interrupt. By fax, would that include through a online medical record, or however prescriptions are done electronically now?
not the way it's written. I don't know if there is a need or interest in changing that.
Well,
I think the
if you
idea was to
put-
have something, I think the idea was to have a physical
yeah,
paper
need to have something
record.
in your
So it's
hands.
either
I see. I
delivered,
see.
mailed, or faxed.
I see. Okay, that's fine then.
Number 14 is that the physician recorded and filed the following in the patient's medical record: the date, time, and wording of all oral requests of the patient for medication to hasten their death. All written requests, so the date, time, and wording of all the oral requests is A. All written requests by the patient for the medication, and B, the physician's diagnosis, prognosis, and basis for the determination that the patient was capable, was acting voluntarily, and had made an informed decision. The second physician's diagnosis, prognosis, and verification that the patient was capable, was acting voluntarily, and had made an informed decision. The physician's attestation that the patient was enrolled in hospice care at the time of the oral and written requests for medication to hasten their death, or that the physician informed the patient of all feasible end-of-life services. The physician's verification that the patient either did not have impaired judgment, or that the physician referred the patient for an evaluation, and the person conducting the evaluation has determined that the patient did not have impaired judgment. A report of the outcome and determinations made during any evaluation which the patient may have received. The date, time, and wording of the physician's offer to the patient to rescind the request for medication at the time of the second oral request. And a note by the physician indicating that all of the requirements under this section were satisfied, and describing all of the steps taken to carry out the request, including a notation of the medication prescribed. And finally, after writing the prescription, the physician promptly filed a report with the Department of Health documenting completion of all of the requirements under this section. And then it specifies that this section shall not be construed to limit civil or criminal liability for gross negligence, recklessness, or intentional misconduct. Then we have that duty to aid, that it's okay that somebody who is self-administering a lethal dose of medication is not a person exposed to grave physical harm, and nobody will be subject to liability solely for being present when the patient took the medication or for not acting to prevent it. And we have the limitations on actions provision that we talked about, including adding some new language. There is an existing exception that allows a healthcare facility to prohibit a physician for writing a prescription of a medication intended to be lethal for a patient who is a resident in the facility and intends to use it on the facility's premises, as long as the facility is notified the physician in writing of its policy. And notwithstanding those limitations on liability, any physician who violates a policy established by a healthcare facility under this section may be subject to sanctions otherwise allowable.
Can I ask a question about that, Jen?
Mhm.
I don't know if you can answer, but was the intent of that so that if there was, for example, a nursing home that didn't want this law to be used in their nursing home, they could say, we don't do this here, basically? you
That is my understanding. I can't
Okay.
speak to intent, but that is my understanding, is that this language would allow a facility to say, we don't do that here.
Got it.
You can't, like, you can't write that prescription and have it be used here.
Got it.
on
Okay.
our
that was
premises.
actually it wasn't a long conversation, but it certainly was a conversation during the development of the bill, of the original.
Essentially allowing a facility to exempt out of. it,
Yes.
or-
Right, allowing a facility to opt out. 5287 says nobody can be denied benefits under a life insurance policy for actions taken in accordance with this chapter, and that medical malpractice insurance and rates cannot be conditioned upon or affected by whether the physician is willing or unwilling to participate in acting under this chapter. There had been concern about palliative sedation. So the chapter shall not limit or otherwise affect providing, administering, or receiving palliative sedation consistent with accepted medical standards. And palliative sedation is giving somebody palliative, I can't remember if it is defined here. It'd be very helpful if it is. Otherwise, we're going on my recollection. No, it's administering palliative medication to make somebody comfortable, recognizing that there is the potential that the dosage could be fatal, but without that being the primary intent. So the intent is to make the person comfortable. Intent is not to cause the person's death, but it is always a possibility. And there was concern that people would be reluctant, or providers would be reluctant to provide a sufficient amount of palliative medication if there were concerns that it could be considered a lethal dose of medication. There's a requirement that the Department of Health adopt rules providing for the safe disposal of unused medications, recognizing that these are medications that are intended to have the effect of causing death. And if they were not used, there needed to be a way to dispose of them safely. Then there's language, statutory construction language saying nothing in this chapter shall be construed to authorize a physician or anyone else to end a patient's life by lethal injection, mercy killing, or active euthanasia. And that action taken in accordance with this chapter shall not be construed for any purpose to constitute suicide, assisted suicide, mercy killing, or homicide under the law. And it should not be construed to conflict with a provision of the Affordable Care Act that also, as I recall, prohibited those activities. Then there was a provision added a couple of years later requiring the health department to adopt rules to facilitate collecting information regarding compliance with the chapter, including identifying patients who filled prescriptions written pursuant to this chapter, and that information would be confidential and exempt from public inspection and copying under the Public Records Act. And then this subsection B is the requirement that the health department generate a biennial statistical report of the information collected under subsection A in a manner that complies with HIPAA. So that is why you get that report that you have just gotten this year that tells how many people use this process, what the underlying conditions were, etc. So that is the language of the existing law.
Okay. Questions for Jen? Go ahead, Ruth. Senator Hardy, go ahead.
So that, going back to that subsection A under paragraph 5, the one that we sort of had up in the air, it's unclear to me, even after going through that, the order of steps. And, one of the things we're trying to do is to, with the bill, is to make it so that there isn't necessarily a requirement for physical examination when they're prescribing medication. So if, is it your understanding that this determination that a patient is suffering a terminal condition takes place first?
First,
Look,
that's the first step, and then there's the steps of requesting the medication.
I think not necessarily. I mean, I think the patient can make the oral request, and that can trigger the physician to have to determine that the patient is suffering a terminal condition. I mean, depending on the relationship between the patient and the physician, that may already be information that is known to the physician, or it may not. It may be something that they have to determine because that request has been made.
Yeah, so that's where it gets complicated, because one of the one of the things we heard in testimony is that by the time a patient requests this medication, they could be already so sick that traveling to see a physician is difficult, and therefore the need for telemedicine is important. So if we don't get rid of the physical here, we may be sort of defeating the purpose. But it does seem strange that there would be no physical examination at any point by a physician. So is there, I mean, presumably they would have had physical examination by their physician who's caring for them for their terminal illness. Like if they have cancer, their oncologist, their primary care physician would have
So if you,
provided a physical examination. Just a second. So is there a way we could link back to that? You know what I mean? So that we're not undoing what we're trying to do at the same time, but also ensuring that at some point in the process, there has been a physical examination.
Yes, I mean, I think you could certainly add something in as part of the determination that the patient was suffering a terminal condition, that if this physician had not done a physical examination, that they have consulted with a physician who has, or something to
Yeah.
that effect.
look at the, I think the summary that Betsy Walkerman has provided is pretty clear.
But
And
that's not the law, Ginny. I'm
no,
sorry. I'm
I
trying to make
understand
sure
that.
it's
Let me
clear in the
finish.
law.
Let me finish. And what it reflects is what actually happens within the medical community. So the question is then on a bona fide physician-patient relationship, that's the question I think that we're asking here is there a bona fide physician-patient relationship? Has that exam taken place? And is this a person who knows the patient? So given that we understand how physicians work in this situation, in particular, Dr. Barnard and her testimony, there's no reason why you couldn't put a link in saying that it says before the physician can write the prescription, the following steps must be taken. They have to confirm that the patient meets Act 39 requirements. And it's in there, and perhaps we could use the term bona fide physician-patient relationship. And I don't know what else we could say, and unless you want to say a physical exam at that point is required. And then you could take the physical exam out later when the person, but we don't know if the person is already at a stage where they can't get in the car and drive to the doctor's office. So it's called the paradox. And Senator Cummings has her hand up, and then Senator Hardy.
Okay. Just looking back at my experience, once you have someone that is terminally ill, there are so many doctors and professionals involved. My daughter she didn't really have primary care because the people that had been doing primary care for years said they weren't doing it anymore. They were only going to do oncology. So she had seen her new nurse practitioner, I think, once before COVID hit. But that's where the original diagnosis came from. Then there was the oncologist, there was the pulmonologist, there was the emergency room doctor, there were the hospitalists when you went in, then there was the OBGYN surgeon. Then when the tissues didn't come back as an OBGYN issue, there were several surgeons, palliative care doctors in the hospital. There were hospice workers from home health, any of whom could say they had a doctor-patient relationship. But there's a medical record out there somewhere But I think what we want is that whichever doctor ends up doing it is a doctor that has a relationship with the patient. I'm concerned, and I think the original concern was you could just dial a doctor, and you would have one doctor that was known that, oh, well, if you just go in and tell him, he'll write the prescription. And so you were I remember those discussions, something about here and walk down the hall and the partner in the same office will say, yeah, you're of sound mind. For the record, I didn't vote for this bill originally. But I don't know that we can define it, because in reality, the minute you hit the hospital, all your other doctors are out of it and you're in the hands of hospitalists. To find the old kind of, I could have said for my doctor, she's my doctor. She was my doctor for 30 years. And she would come see you in the hospital. That doesn't happen anymore. To find a doctor that really knows you in these circumstances, I think would be a rarity. There's just too much specialization, and I don't know how you deal with that.
Well, I think currently we have had a good experience in our state with this program. And we did hear from Dr. Barnard how the doctor-patient relationship is formed. So I'm concerned that we don't want to go backwards or too far into the underlying statute, but we do want to be sure that we're clear on what's happening. Senator Hardy, go ahead.
Thank you, Senator Lyons, and thank you, Senator Cummings, for sharing what I know is a difficult experience. I think, Jen, on that section that we're talking about, 5A, it might work to just change the to an A, so that it was suffering a terminal condition based on a physician's physical examination. So that would imply that a previous physical examination that diagnosed the patient had been in person, but the current physician that may be providing the medication wouldn't necessarily have to have done that physical examination. Does that make sense? And it seems like a simple change. But
Nothing's ever simple, but it sounds really good.
well, I mean, simple in that it's a
I
simple
know.
wording change, but it might get to our concerns that there will have been a physical examination, but it doesn't necessarily have to be within this really tight process at the end when somebody's really suffering. And I think that given the fact that bona fide physical physician-patient relationship is never really used in the statute, it may be best to actually get rid of it so there's not confusion, but I don't want that to become controversial to get rid of that.
I think I agree with you, but it's also the last thing you said is it could become another hot issue. We'll think about it. Senator Cummings.
Could we say a physical examination somewhere in this chain and confirmed by the medical record?
Right, and that's actually in the, I think in the
It is in
bill,
there already, Anne. Actually, it
they
says
do
based
a
on
medical history that determines that, and they examine the patient and their medical history to determine the patient's status. That's in there.
so
Okay.
it's
Right, so the language of 5A currently is the physician determined that the patient was suffering a terminal condition based on, and we might be changing that to based on a physician's physical examination of the patient. Maybe we say, and the physician's review of the patient's relevant medical records. Maybe we even flip those so it's clear that it's this physician who's doing the review of the patient's relevant medical records and a physician who did the physical examination.
Oh,
Does
that
that
is
make
so
sense?
good.
Yeah.
Good work, Senator Hardy.
Trying to get to yes here.
Okay. Is that the last thing or not? Where are
Yes.
we?
I think so.
Yeah, I thought so. Okay. All right. It is 11:20. Before Senator Hardy has a comment, Jen, how long would it take you to put together a new iteration?
I can probably make it pretty quick,
Okay.
maybe 15, 20 minutes.
Okay, well, let's do that. Let's ask for you, please, to do that. It would be great. And then we'll come back and look at it. And then we will, we won't vote, but we'll take a chance, we'll take some time overnight to consider it. And then perhaps
Great.
tomorrow we'll be able to vote on the bill. We'll have some time after we meet with the House, I think, although our schedules
So
are
that's great.
always.
I will bring you an unedited version and I'll get it edited while you're considering.
Senator Hardy.
That's great. I was just going to say one added benefit of Jen updating the gendered language is that it will have more language in the bill, so it will probably be less confusing because it will be less out of context.
Yes.
Are
and
you
we'll-
wanting me to make the changes throughout the chapter or just in the sections we're already working with?
Let's just do the sections we're working with. If you do
Oh.
it throughout the bill, then it opens up the entire bill for scrutiny and amendments and everything else. And I know, frankly, I know that whichever senator presents this on the floor is going to do a great job. So, all right, let's Aaron, let's go off YouTube. We're on break for what, until 11:40, Jen?